guys, I am going to tell you about celiac disease in today's video. Celiac disease these days is actually pretty common. A lot of people who have received that diagnosis from a practitioner or suspect that they may be a celiac patient and therefore forego eating gluten and largely a lot of things that contain gluten, so bread, pizza, beer, things of that nature. So it's something that most people on some level are familiar with. And we're going to talk about kind of what it means and what the immune response behind it leads to celiac disease, and also kind of the diagnostics and why your friend that comes to you and says, you know, I think I might be celiac, so I just stopped eating gluten, and then tells people that they're celiac, might not actually be wrong. So what is celiac disease? So first off, celiac disease is known as celiac, gluten sensitivity enteropathy. It's also been known as non-tropical sprue or celiac sprue. And basically all it is an intestinal inflammatory disorder induced by a food antigen. And that's actually really key. So this is a food antigen, can't write here, induced hypersensitivity. So normally when we think about food antigen induced hypersensitivities, we think about type 1 hypersensitivity. We think about allergy. Here's where things are different. Celiac disease is actually thought to be a type 4 hypersensitivity. So most of our type 4 hypersensitivities are against self-antigens, but this one is against a food antigen, like type 1s. But it's almost entirely T-cell mediated. And we know that a person's HLA haplotype plays a huge role in their susceptibility to disease. So it's a type 4 hypersensitivity that's induced by a food antigen, okay? All right, so like other type 4 hypersensitivities, we're concerned about the CD4 and CD8 T-cell responses that are being made. The difference here from most autoimmune diseases is that it's a food antigen. You may also see autoantibodies present, and sometimes these are used for diagnostic purposes. The antibodies actually tend to precede disease onset and are not thought to actually be part of the pathogenic or immunopathogenic process, all right? So like many autoimmune and hypersensitivity disorders, there's kind of three things that play a role, right? Your genetics, your environment, and immune regulation, how your body responds to this combination of environment and genetics. There is a pretty significant genetic correlation here. So if you are a monozygotic twin, identical twin, and your twin gets diagnosed with celiac disease, 75% of the time, you will also get diagnosed with celiac disease. However, in the general population, there's only about a 1% risk of actually being diagnosed with celiac disease. And the inheritance rate for like a first-degree sibling, like your brother or your sister, is about 10%. So we know there's some genetic thing, but actually the strongest genetic component is this one. 99% of celiac patients have one of these two HLA haplotypes, either HLA-DQ 2.5 or HLA-DQ 8, okay? Now, about 35 to 40% of all Americans are these two haplotypes, okay? There's a whole bunch of us that are one of these two haplotypes. So of that 35 to 45%, a small percentage, only 2 to 3% of them will develop celiac disease. So 2 to 3% of the 35 to 40% of Americans that are HLA-DQ 2.5 or HLA-DQ 8. And the reason why these two haplotypes are so important is actually that these two haplotypes lack an aspartic acid. And this aspartic acid basically changes the overall charge. So what it does is it creates a positively charged binding pocket, which contributes to the ability of that MHC molecule to bind the negatively charged gluten antigen. There are also a whole bunch of non-HLA antigens that may contribute to the predisposition or inheritance of celiac disease, but I just want you to focus on HLA. Okay, so what does celiac feel like? Bad. So there's a couple main features. So historically, we actually thought of celiac disease as a disease of infants, okay? So you'd have wasting, failure to thrive, significant gastrointestinal distress in infants and young children, and children would potentially die of celiac disease. These days, we're actually able to diagnose less severe causes of celiac in patients in their teens, 20s, 30s, and 40s. So it can kind of present over the lifespan of a patient. The classic presentation of celiac disease it really includes three features. First off, villus atrophy. So the villi within your intestines, they atrophy and go away. They're destroyed. And because of that, we get symptoms of malabsorption, weight loss, certain vitamin deficiencies, steatorrhea, which is basically just excess fat in the feces, so your poop floats. And then the way to actually make all of this go away is actually the third feature of celiac disease. You stop eating gluten, and suddenly all these problems go away. So patients with celiac disease are typically going to present with diarrhea, weight loss, malabsorption, and they'll probably possess antibodies against gliadin, which is one of kind of the earlier forms of gluten, or against something known as TTG, which we'll talk about in a minute with the pathogenesis, which is tissue transglutaminase. And as I said before, they have the specific HLA haplotype. The symptoms can vary significantly patient to patient, and they may come and go, especially early in disease where they can be triggered. So you're a teenager, you go to a party, you eat a ton of pizza and chips and things that contain gluten, and for the next 2 days you feel terrible. So all you eat is like broth and salad and you feel great, and it's really just that you haven't been getting your antigenic trigger, so you're not experiencing the disease. There is this skin manifestation, dermatitis herpetiformis. Sorry, I can't talk today. Dermatitis herpetiformis. This is a complication of celiac, which is what I'm showing here. This is a papular rash that occurs when IgA antibodies in the blood bind to the epidermal tissue transglutaminases on the dermal papillae. And neutrophils in this case would be recruited to the areas where the IgA binds, and that causes inflammation leading to the rash. The other thing that I'll say is patients with celiac tend to have an increased risk of T-cell lymphoma and small bowel adenocarcinoma because we're constantly amplifying and stimulating these cells. Okay, let's go through the immune mechanism. So first off, a little break for biochemistry. I know I'm not a huge fan normally of biochemistry, but here it's really important. First off, the gluten protein actually consists of 3 separate gliadins listed here. It also has a high and a low molecular weight glutenin subcomponent, but both gliadin and glutenin proteins are capable of inducing disease. So I'm just going to use the term gliadin because it's a little bit easier, okay? All right, so basically you have this partially digested gliadin, all right? Gliadin is not typically broken down by gastrointestinal enzymes in celiac patients. It's instead bound by a secretory IgA. So I'm just going to draw myself a secretory IgA here. And so it's bound to that gliadin, all right? This normally leads to the removal of IgA from the GI tract, but in celiac disease, the IgA gliadin complex actually gets bound to the tissue transferrin receptor. And that's actually supposed to bind iron, but instead it's binding to IgA gliadin components. The tissue transferrin receptor actually is what leads to it crossing our epithelial barrier. And it's thought that the tissue transferrin receptor is actually overexpressed in patients with celiac. So this IgA gliadin complex is transcytosed across the enterocyte into the lamina propria, where an enzyme, tissue transglutaminase, which I talked about earlier, basically removes an amide group. So it deaminates the peptide, okay? So when it removes this peptide, we now have deaminated gliadin. Deaminated gliadin is then eaten up by a local antigen-presenting cell, probably a macrophage, but it could be like an immature dendritic cell if this is early in the process, so that the immature DC could go to the lymph node where it could prime T cells and kind of kick this whole thing off. So this is where this antigen presentation thing comes in. So this is where we can actually see this importance of the antigen presentation, because it is literally only the HLA DQ2 and DQ8 that are actually able to bind the deamidated gluten. Okay, so if you didn't have deamidated gluten, then it wouldn't even be a problem. And if you didn't have HLA DQ2.5 or HLA DQ8, you wouldn't be able to bind the deaminated gluten. So it's kind of a chicken-egg situation. So gluten-reactive T cells preferentially recognize epitopes that have become post-translationally modified by the enzyme TTG, so tissue transglutaminase. All right, so then what happens? Well, we prime our CD4 positive T cells and we get kind of a typical Th1 response, complete with interferon gamma and TNF alpha. Once you have these cytokines in the mix, a couple of things happen. One, we're going to activate CD8 T cells, okay? So the Th1s produce interferon gamma. They're probably also going to help with secretion of IL-12, which will promote the CD8 and NK immune response, and that can lead to direct lysis of some of our enterocytes. You also see fast ligand-mediated cell apoptosis and generalized toxicity as a result of interferon gamma and the tumor necrosis factor alpha. Also, all of this inflammation is just really bad for the normal balance of the gastrointestinal tract. The T helper cells will also affect the plasma cells. We're going to see secretion of IgG and IgA. You can see this graphic has some Th2 responses, which is going to lead you more toward IgA, which is more common in the mucosal compartment, and that is present there. Th2 can be inflammatory. It's just not as inflammatory typically as Th1, unless you're kind of worried about like anaphylaxis. Lastly, all of this damage, you've got those CD8 T cells, they're going to be really damaging to those villi. And that's actually key for how we discuss the diagnosis and the pathology of celiac disease. Okay, so I'm not a pathologist, but I will kind of do a little bit of a description here. All right, so the intestinal lesions of celiac disease are really associated with how many of these finger-like villi we're losing, okay? So the finger-like villi are normally required or used to increase the absorptive properties of the surface of the gut. But what we see is we see them go away. This is a patient with really severe celiac disease, their biopsy. So you can see there's no villi that we can really differentiate here. You also see increased cell division of the epithelial cells in the crypt. This is known as crypt hyperplasia. Diagnostically, we can actually kind of think about celiac disease along the Marsh classification, which basically includes the earliest pathologic abnormalities seen in celiac disease, which is an increased number of intraepithelial lymphocytes on small bowel biopsy, to a much more severe pathology like I'm showing here, which might include crypt cell hyperplasia, marked atrophy or total loss or blunting of the villus, depending on the severity. Okay, so let's talk about diagnosis of celiac and self-identification versus clinical diagnosis. This is kind of a hot button right now. Many people self-identify as celiac. And you know what? I know that this can be somewhat controversial, but here's what I'll say as someone who does not suffer from celiac disease. And I know that this can be a more personal conversation for those that do. I do take the official clinical diagnosis of a condition very seriously. This goes, into your medical record. It can impact access to medication. It impacts, obviously what you eat and how you live, and frankly, also how seriously people take your diagnosis. That said, I take human pain and suffering very seriously as well. I think that the majority of people who self-identify as celiac have very good reasons for doing that. They probably did not feel healthy when they removed gluten from their diet. they felt better. And that is kind of one of our major features of celiac disease. Now, one of the things I will say is that true celiac disease is an intolerance to gluten. The foods that contain gluten also contain many other things that may lead to inflammation. So it's possible that not eating gluten made you feel better, but that it has nothing to do with gluten. That said, following a gluten-free diet still fixed your problem. So I see why you would just go ahead and say, yeah, I have celiac disease because not eating gluten makes me feel better. The other thing I'll say is that, you know, if your outward symptom is symptoms similar to celiac disease and you stop eating gluten and you feel better, when you go and talk to your doctor and say, hey, I think I might have celiac, and they say, okay, we can test you, but it's going to cost, you know, significant sums of money and time. And oh, by the way, you probably will have to go back on a gluten-rich diet in order to determine if you actually are gluten sensitive. That's not really very attractive to many people who have just kind of kicked the gluten habit. So with their practitioners, they may make the decision that, like, yeah, I am probably a celiac patient, but I'm not going to go through all of this just to get a piece of paper so that I can tell people, no, I actually got diagnosed. I mean, that just seems silly. So really, as long as you're feeling good and you're making good decisions with your practitioner, it's nobody's business but your own, is kind of my take-home point. So anyway, off the soapbox and onto the science. How do we actually diagnose it if we wanted to? So first off, as I just said, for many of these tests to work optimally, you need to be on a gluten-rich diet. So even if you stopped eating gluten, now you have to restart eating gluten in order to get the a positive result, okay? So you can do a serum IgA test for anti-TTG or EMA, and testing for IgA can be useful in diagnosis, but it will not identify the now more common, less severe cases of celiac. So this test is really good for really severe celiac patients, and this is kind of what we would expect of like those kids that get diagnosed as celiac really, really young, or people who have exceptionally severe celiac. And again, they need to be eating gluten at the time that they take the test. You can do serum IgG for anti-TTG or anti-gliadin. This one is actually very effective for identifying celiac patients, but again, you need that gluten-rich diet happening actively. You could also do an endoscopic biopsy of the duodenum, and that would basically reveal the crypt hyperplasia with or without flattening of the villi, depending on the stage of disease. However, getting an endoscopy and a biopsy is super invasive and super expensive. So, you know, it's kind of a big ask. Also, sometimes small bowel biopsies are normal if the patient has not been consuming gluten. You know, the body says, oh, good, this inflammation isn't happening anymore. Let me repair. So if that's the case, then, you know, you could go through this whole endoscopic biopsy and not see anything. So it's something to consider, particularly if your patient is actively eating gluten. Patients with celiac disease are known to have increased intestinal permeability, so just something to kind of keep an eye on. Okay, so what if you have a patient who has been enjoying a gluten-free diet for many months, maybe years, and says, you know, I've always suspected I'm celiac, but now I want to confirm it. So how can you confirm it without having them go pick up the bread? So for patients who are unwilling or unable to go back on gluten-containing diet, the first step is, once again, do those serologies. They may be negative because the patient has been maintaining a free diet. If that's the case, try that HLA haplotyping. If your patient has suspected that they were celiac for a long time, went on a gluten-free diet, and then saw their symptoms resolve, and they are either HLA DQ8 or DQ2.5, there's a pretty good chance that they're a celiac patient. If they are not DQ8 or DQ2.5, really you should eliminate gluten from your differential. I mean, not completely, but it knocks it way, way down, because really 99% of celiac patients are this haplotype, so it would be very, very unlikely. But patients who are well controlled on their gluten-free diet may choose not to do the gluten challenge. And there's nothing wrong with that, and it does not make them any less of a celiac patient than somebody else, really. And really the treatment, as I've said about 8 million times in this video, is easy. Instead of saying pass the bread, pass on the bread, just avoid gluten.